stop and go all you wanted to know about imaging and this time physiology guidance. Haibo from Harbin, please tell us what is Harbin as an hospital, as an activity.
Okay, yeah, thank you, Dr. Ji. So I just briefly introduce our hospital. Our hospital was built in 1954, based in Harbin, northeastern of China. This hospital has a huge area, which is ranked the biggest general hospital in Asian Pacific area. Total area of 500,000 square meters. We have over 3,000 beds and over 4,400 faculties. And for our department was built in 1978. So from 2012, we moved from Prof building to the current building. So now we have 8 units to CCU. CCU, we have 80 beds, which was the biggest cardiac CCU in China. Now we have almost 600 beds in cardiology department, doctors over 130. We have 264 nurses, 14 technicians. And so this volume, we recommend the biggest cardiology department in general hospital in China, and also rank top 7 best cardiology in China out of more than 500 hospitals. So this is just a few pictures of our cath lab and the CCU and our follow-up centers. This is the so recent 4 years our work done in our cath lab. Overall average about 8,000 to 10,000 PCI cases, including imaging, good number of imaging cases. Okay, yeah, that's right. That's our whole family of cardiology, over 400 doctors and nurses and technicians. Thank you. Welcome to Harbin.
Super. So all of this department is guided by Professor Yu, and you can see the role of Professor Yu in the Chinese Society of Cardiology and the Asia Society of Cardiology and many other things. Professor Yu, do you want to address a few welcome words about this meeting we are running in the next 2 days?
Dear my friends and the audience, it's my great honor to welcome you to join 2022 Harbin Interventional Imaging and Physiology course. Last year, we had a very successful meeting with a total number of online audience over 12,000 on Friday and 16,000 on Saturday. This year, we hope to reach the peak again this time. As the course director, our goal is to share the experience intravascular imaging by live cases, to understand how imaging can improve PCI results with the procedure planning and stand optimization. Our center performs many complex cases each day. Last year, the total number of PCI cases was more than 10,000, including 2,015 primary PCI. Over 40% PCI were guided by OCT or EVAS. Our department have independent cardiovascular imaging center and performed more than 10,000 cardiac CTA and MIR. I hope to reach middle and senior audience in the whole Pacific region and Europe. All
Thank you very much.
Panelists are the best recognized imaging and for physiology experts from the APAC and Europe. the efforts and cutting edge views of all champions and panelists are the key to success of this meeting. Especially thanks to the Dr. Guagliumi for your tremendous work and efforts dedicated to preparing for this course. I hope program will have great success. Thank you all.
Thank you. Thank you very much, Professor Yu. And let's go quickly to the way we are going to interact. Now you know the Harbin Cath Lab. You still do not know the lady who is leading this incredible group. The format we will face during this day is going to be this one. We are across the globe. You will see faculty from Europe, for all the countries in Asia that are going to stay connected with the Cath Lab, but also connected with you through what? Through the chat, because we wanted to have the audience fully presented with us. Here is the incredible panel of the people you may interact during this day. They are coming from Singapore, Japan, a different country in Europe, all across China, and many, many other countries. So very happy to have them on board. 2 days focus on complex PCI, and we will start soon to try to get this interaction in terms of a question, suggestion through the chat, but not only. We launched through WeChat a few days ago one single picture of the case we are going to deal today with some essential information based upon imaging and physiology. And we ask you, how would I treat? The format is now stopping my talk and switch the ball to Wei Che Jack Tan from Singapore, who is going to be the leader facilitator of the next case that is talking about a young man with a stable angina and multivessel disease. Wei, ball to you.
Thanks, Dr. G, and thanks to the Harbin group. I'm really quite excited to facilitate today's session. My name is Jack from the National Heart Center, Singapore. I'm really wanted and I'm very excited to go through this case of a young patient with stable and multi-vessel disease. So quickly, so thanks everyone. I'm also very excited to go through this case of a young patient with stable angina and multi-vessel disease. Quickly, it's a 44-year-old male gentleman with a history of smoking that has a clinical presentation of stable angina. Before an invasive intervention was done, the patient had a CT with CT FFR performed as well. So the key objective of today's session, we want to discuss actually the role of CT angiogram plus minus a CT FFR to inform on the global procedural strategy and how do we treat even before the patient lands in the cath lab. We also want to then have the cath lab demonstrate how do we treat calcified lesions, when do we need to anticipate aggressive lesion preparation. And last but not least, in a diffuse disease subset, how do we use physiology, FFR, RFR, or OCT to optimize the procedure and stents. So before we go in, I put up this slide to just discuss with the group. I think this was just recently published early March in New England Journal. The discharge group, our European colleagues actually had this nice publication. Do we actually start off with invasive coronary angiogram or CT angiogram in a stable angina group? And the conclusion they had was that for stable angina and perhaps intermediate pretest probability of CAD, the risk for major cardiovascular events was similar if you start either with a CT angiogram or invasive coronary angiogram. But the frequency of major procedure-related complication was far lower in the CT strategy. So we can discuss that. I think without further ado, I'd like to then switch to the cath lab. So we have a pre-procedure CT angiogram, which we'll discuss further, but we'll now like to transit to the cath lab at Harbin for Professor Hao to lead us through what we don't know yet, whether angiogram alone is enough, whether we need physiology, whether we need intravascular imaging for this young patient. Back to the cath lab at Harbin.
Hello, Jack. Can you hear me?
Yes, Dr. Hao, we can hear you clearly. Are you able to share screen on the cath lab?
Yeah. Can you see the cath lab?
Is it on the main screen now? Yeah, I can see you if I pin your, yeah, that's good. Please go ahead.
But
Okay.
we still have your face way on the full screen. We wanted to have the cat.
Please transfer to the cath lab. Hello, Jack. Hello, everyone. Good afternoon. Can you hear me? Can you see the screen?
Very, very clear, Dr. Hao. Please go ahead.
Thank you. Yeah, I can see you. And I think that the first I introduce our team first very simply. And today, my assistant is Professor Chen Tao, and technician is Professor Yu Huai, and the nurse is Zhang Qian. Our team together to give the live case together. And I'll add some information for this patient. This patient is very young, and the patient has a family history, and his father has the coronary heart disease, with sudden death, and the patient has diabetes and with the obesity. And today, you are very curious because you first see the CT result for the angio. And from the CT, we notice that maybe the most serious stenosis is along LED and diagonal. And maybe from the CT FFR, we should notice the LED, the circle, and the diagonal. But maybe you are very curious about the angio result. And now let's see the angio result for this patient together. I think that it is very different result from CT result. Please change to the angio to the cath lab. Please change to the angio. Can you see the angio result?
Yeah, we're looking at the angio, looks like the spider view or the lateral view.
Yes. And you can see the result from the spider view, and with some the serious stenosis along proximal circle, and some problems with the very high OM, and then go to LED and the diagonal. And from this view, you can see that we have some problem, moderate stenosis along LD, the middle LED. The next. And this way, and you can see clearly the big diagonal and the proximal site of the big diagonal with very tight stenosis. And maybe the length is about 5 millimeter. And a diffuse lesion along proximal to moderate to the middle of LED. So now let's go to the RCA. And from the CT FFR, we know less the RCA, the CT FFR of RCA is just negative, but you can see the result from the angio. And the angio for RCA, you can see the near subtotal occlusion at the bifurcation site of the distal RCA. So now this is the angio result of this patient. And the panelist, and let's discuss how to treat this patient.
Very, very, very interesting case, Dr. Hao. So very young, truly multi-vessel disease. I'd like to now welcome some of our expert panelists to give some comments. First, Dr. Eugene Wu from Hong Kong, your comments about how you actually treat this patient as well.
Okay, so we have new information on the angiogram. The right coronary artery seems to be much tighter than the rest, but it seems to be an easy lesion. So maybe we should tackle the right coronary artery first. The LAD is a big territory, and on the CT FFR, it's a very low value. which makes it quite difficult to get full ischemic revascularization for the LAD and that diagonal. So I would like to do pre and post FFR, RFR to the LAD and diagonal if I'm going to treat the LAD and diagonal in the same sitting. The LAD is very diffusely diseased and calcified, and it's a very big vessel. So we need to do arthrectomy. Just using a balloon alone is not going to be enough, even a shockwave balloon. We need to get good expansion. And in big vessels, orbital arthrectomy will give you a bigger arthrectomy size. If you don't have orbital and use rotor, you probably have to bias the rotor burr to different size to get that big arthrectomy. So you might need to rotor down diagonal as well as the LAD to get that result. And of course, is a big diagonal, you may need to take about 2 stents. In a young patient, you should do minimum metallic overlap stenting. For me, in my cath lab, I will do 3D guided single string culotte. So stenting the side and then stringing one strut out and stenting the LAD. That will allow this patient very minimal metallic overlap for better long-term outcomes. So those would be my ideas.
Thanks, Eugene. So Eugene would like to treat the right and physiology, imaging, and probably arthrectomy to the left. Dr. Barbato, will you do the same or any difference? This is quite an interesting case.
Yeah, it is. Let me just quickly recap. We have a 44 years old gentleman, very young, obese, diabetic patient. So I think it's a must at least to have a chat with our cardiac surgeons and discuss the best strategy, especially because this patient has multivessel disease. In favor of surgery, certainly diabetes and multivessel disease. Against surgery is the obesity and, let me say, young age. I mean, if we offer full bypass revascularization at 44 years old, the chance that these patients will need additional interventions in his lifespan is pretty high. So that would make me portending for percutaneous coronary intervention. And now we come to how to do this. I agree with my colleague that the right seems pretty an easy task. It's a focal lesion, easy to be treated, no problem. On the left, I would like to know more. And I would like to know more by a careful reading of CT, and I'm sure we will do that later, because I need to understand whether there is calcium involving more than 2 quadrants, more than 880 degrees. So yes, so we need plaque modification technique, and in case rotational or orbital arthrectomy can make the job there. And an additional information I need to know from physiology here is whether we have a focal gradient or a diffuse disease, because I need to understand how long has to be my standing strategy there. And last but not least, there is also this ramus angularis that is involved. It's not just LAD and diagonal branch, at least from Angio. I also had the impression that the ramus angularis is involved, and we might deliver also there some treatment. Back to you.
Thanks, Dr. Barbato and Eugene. Dr. Hao, maybe you'd like to tell us what actually is your plan for the moment. Dr. Hao, are you?
Yes.
Yeah, go ahead.
Hello, Jack. I think that some part agree with the panelists. And from the angio, we know that the most serious stenosis is along the distal RCA. But I think that maybe the LED and the circ, we need some help from the imaging and FFR and to determine what kind of strategy. And so at first, I must solve the tight stenosis of RCA very fast because the multivessel disease, and we must very simply and to just solve the problem of RCA. And again, to the distal of RCA, this is 2.5 balloon to dilate it, and I choose 3.0 and 33 stent. I don't want to do pre-OCT because I don't want to use too much contrast along RCA, and then to dilate the stent and to post the dilatation with 3.0 post NC balloon. And this is the result of the angio. After that, and we do OCT examination for RCA to make sure about the safety of the RCA stent. And so now let's turn to the RCA OCT. Can you see the OCT result?
Yes, we can see it now. Please go
yes.
ahead.
Because it's very distal and with tight and some I think that not very stable image of OCT, but we can see clearly and the distal part of the stent without dissection and proximal part of the stent is okay. And just for the area of the stent, it's just suitable for this patient with good expansion. And so we notice that from the CT with some calcification along RCA, the middle RCA and the proximal RCA, but from the OCT examination, and you can see that just the middle and the proximal part of RCA without a serious calcification. Can you see the OCT image? Yes, I can see it.
Yeah.
You can see that with some just lipid plaque and some very thin calcification, but not very serious. And so because I want to leave the problem of left coronary artery to use imaging and the FFR physiology to determine the strategy. So I just saw the RCA problem very fast. This is the result of RCA, and you can see the final result.
Any comments? Eugene, this is what you wanted, right?
Yes, this is exactly what I was hoping for, which is good. But this, of course, is the easy part.
Yes,
So
I think that, yes, Jack, this patient is very complicated because I don't know from the angio how to treat LED, diagonal, and the circ, and the OM, the big OM. So I just use minutes and to solve the RCA. Now let's go to the left coronary artery. Jack?
yeah, please, let's go to the left, and maybe you can let us know where you are now and what's your strategy.
Yes, I think like because we now have problem from the left coronary angio, the problem with the diffuse middle LED, and the big problem for the diagonal, the big diagonal, and some problem with the proximal circ and the big OM. And so we first determined to do FFR for LED, diagonal, and the circ and the OM. So now we already have the result. Can you guess the result for the 4 vessels?
Babato, you want to comment your guess?
Yes, would be nice if you show us the pressure tracings. If you already acquired that, please show the pressure tracings.
Would you be able to show us the pressure tracing that was recorded?
Okay, and now I'll give the panelists the result for the FFR. And first we do diagonal FFR, and this is the FFR guide wire into the diagonal. And the result for the diagonal, can you see on the screen? Maybe, yes, you can see. The result for the diagonal is 0.73. It is positive for the diagonal.
Please
And I just pull back the guide wire, and really just the diagonal proximal part has the difference of the pressure. And so then I give the measurement for the LED. LED pull back, you can see the distal part is 0.67. And then I pull back, and you can see here is the middle LED. Here is, yes, 0.75. And then back to the proximal. Proximal, you can see the result is 0.85. And then the root of LED is more than 0.90. Yes, 0.94. This is a pullback along LED. We can make clearly that the just pressure difference is along the middle LED. And then we have some difficulties to put the FR guide wire into the OM and the circ. but we resolve it. And so you can see this is in OM. And the OM, the value is 0.82, is negative. I think that this is a happy news. And then for the circ is the most difficult to FFR get wire into it. But at last, away to the distal of the circ. And so you can see the value is 0.75. So now list all the FFR values. So
Thanks,
I think that Jack and the panelists.
Thanks, Dr. Hao.
Okay.
Babato, you want to make some comments
Well,
about
very-
whether
very-
you think the LED is diffuse or focal based on the tracings?
Yeah, very, very quickly, what we learned from this pullback of the LAD, actually, that was the most interesting one, is that there is a background of diffuse disease with some focal disease as well on top. What does it mean? That we can help this patient with a segmental treatment, with stenting, in other words, but let's not expect that post-PCI FFR will be normalized. There will be always some residual degree of atherosclerosis that we will not normalize with our stenting, but now we know it. We know that we can treat with a long stent in this mid-LAD, and we need to further work with secondary prevention in order to address the remaining atherosclerosis. That would be my take-home message.
Thanks, that's a great point. So Babato is expecting that in spite of your best imaging guided result, it may not have an impressive result for FFR in the final LAD. Dr. Hao, maybe you can tell us your strategy before I leave you from the cath lab.
Yes, I think that maybe we have the just the negative for OM. I don't want to put a stent or do some PCI to OM. And then I think that for the not so big circ, 0.75 is okay for FFR. And so I think that leave it to the follow up. And I must do PCI to diagonal and IOAD. But from the CT, we know that the middle part of the IOED have the serious calcification. So we must need some imaging information and to make sure about the serious severity of the calcification. And so I determined to do the OCT examination for diagonal and IOED. Jack?
Yes, thanks, Dr. Hao. Do you want to show us those, or we'll leave you and we'll come back to you later?
You can see the OCT and for diagonal and IOED, and then I will perform PCI, and, and then we will back. And so now let's see diagonal OCT, the IOED OCT first, please.
IOED.
Can you, Professor Yuhuai, can you introduce the minimal lumen area and the calcification area?
MRA is 1.14 here. And the calcification, someplace I have measurement. You can hear.
Proximal, yeah.
Yeah. 0.67.
You can see this is near a circular calcification, but the thickness is near 1 millimeter, very thick, but not regular. Some part is thin. And so now let's go to the bifurcation part. Bifurcation 从
okay. I got it.
Okay, I want to see from the IOED view and to see the bifurcation diagonal.
So Eugene actually initially thought you need some form of atractomy, so maybe you can get one quick comment later, whether with the intravascular imaging, Eugene still thinks we need some form of atractomy here.
I think so. I still think it's very thick. It's 0.67, even at the minimal area. So it doesn't predict a good outcome if you don't do arthrectomy.
Okay, and now let's go to IOED. This is the real bifurcation, and you can see the diagonal OCT. Diagonal OCT.
Yeah. Diagonal OCT.
the diagonal OCT, when the OCT get very into the diagonal and the blood flow is limited, but we really get the picture, OCT picture for the very stenosis part. And you can see minimum lumen area is very tight, very, very small. And we can notice that with the circular calcification, very thick.
So Babato, will you think that this needs an upfront 2-stent, or can it be a provisional strategy here?
It's a true Medina 1-1-1 bifurcation here. The chance that we might need a second stent is quite important. Yet we can always start with a provisional stenting strategy. You know, we can always be able to implant an additional stent. I'm quite confident we wouldn't lose the side branch. But again, that's a decision that only the operator can take, because he has the flavor, the touch of the quality of the pre-dilatation and plaque modification, which will be necessary in this case. So I'm curious to see the treatment.
So Dr. Hao, we're going to leave you, and before we come back, where you'll tell us what have you decided later on.
Okay.
Thank you very much. Yeah. So just going to quickly share screen again. So thanks a lot for the expert commentary from both Babato and Eugene. Next, we actually have our audience participation, where they will put on some question. They will actually ask how they will treat this patient. Is it medical therapy, surgery? Is it some form of hybrid intervention? Or are we going for a complex PCI? And do we need any decision by angio intravascular imaging? This was a result from the audience. Dr. Jia, do you have any comments? So most of the audience, like what rightly has been demonstrated here, think that you will need some imaging to guide any form of complex intervention. So actually, I would like to then transit a little bit before we go back to the cath lab to ask some of our panels on pre-procedure CT strategy planning. Dr. Yang Qi in China is the first go-to strategy for pre-procedure planning a CT angiogram. Dr. Yang?
So, Dr. Tan, so I think this is very interesting case, relatively young, only 44 years old. We noticed that on the CT angiography, there is diffuse calcification in diagonal and proximal RAD. So I think physiology, since the patient has the history of diabetes, I think I agree with Dr. Ho and Dr. Jia. I think based on the imaging, PCI, and physical, even with the other imaging technique, we may also care about the perfusion, whether there is some abnormal myocardium deficits in the I think in the heart, also important, since I think FFR is only measuring the large vessel. Since the patient has diabetes, we still need to care about the perfusion for the patient.
Thanks, Dr. Yang Qi. I'm not too certain whether the patient has diabetes. I thought just a smoker and fairly young. But in China, is the usage of CT angiogram very common now as an investigation?
I think actually I'm also from the hospital. I studied in the same hospital as Dr. Yubo and Dr. Jia. I grew up there. Now I'm working in Beijing, and it's quite common in China due to the insurance. It's a big difference with I think between China and the European countries and the United States. You need a code in the United States, but in China, I think that the hospital, this cardiovascular hospital, they can own their own they have their own dual source CT, so they can perform CT angiography, and the insurance will cover almost most of the expense for this kind of patients. And also we can do the CT FFR. We can have the QFR. I think, but to tell you the truth, in the last several, I think 10 years, a lot of the physicians care more about the stenting, but now we care about the balloon. So this is also due to the insurance. I think they have the things change. So I don't know. I think physiology and imaging, myocardium, perfusion, I think functional, everything is more, I think, deep in. We need to find something imaging based. We can see value based imaging for the heart. So Dan Berman, we're quite familiar with Dan Berman from United States, from Cedars-Sinai. We've been worked together for several years. I think he's a pioneer in the field of PET for the myocardium. They talk more about the value-based cardiac imaging in United States. I think we are changing in China. So
thanks. I think it's still evolving and a lot of complex issue regarding what test is done. Maybe that makes me want to ask Daniele then to ask, in his view, for example, in this case, how do we actually want to use CT angiogram, particularly CT FFR, to guide the intervention? And is that your practice, Daniele?
Yeah, thank you, Jack. So, so we saw by looking the angio that the diagnosis by CTA of 3 vessel disease was correct. In fact, we have a very long lesion with a functional significance in the LAD. We have a tight lesion, subocclusion in the distal right, and a long lesion in the circle. Here in this slide, we have, in the previous one, sorry, we have a different reconstruction of the LAD. On the left, you can note in the straight MPR that we have a very long lesion in the LAD with a different plaque composition. You can note in the cross section. Above, we have the first lesion that correspond in the FFR CT to a big delta. And it was nice also to see the very nice correspondence between invasive FFR and FFR CT, 0.67 in the distality of the LAD. You can see in the cross section, the first lesion was a mixed one with a calcific nodule, 6 to 9, and a lipidic component that give to the big delta in the FFR. Probably most interesting for the planning, the 2 cross section related to the calcific plaque. As Emanuele mentioned previously, we can try to anticipate the need of some plaque modification technique, such as ROTA or IVL, if we find an arc in cross section of the calcium superior to 270 degrees. In this case, in the 2 mid cross section, you can see that the arc is high, is almost 360. However, you can note that the center of the lumen is free from calcification. So this means, in my experience, that sometimes in this case, just a non-compliant balloon may be enough. My only concern here regards the very distal part of the calcification, where, as you can see in the cross section, the calcific part is a little bit thinner. So I'm thicker, sorry. I'm very interested to see what's happening in the cath lab regarding the use of IVL. So we can pass to the next and then to the right. Here, the reconstruction is very good again, and we are a vessel dominant for distribution with good caliber, and just the very tight lesion in the distality. You can note the cross section that showed a non-calcific composition, including a larger lipidic composition. And exactly at that part, we have the drop in the FFR CT. So again, this predicts a very simple PCI as we saw live in the cath lab.
Can I just ask you then, just based on this, the right looks very tight, but the FFR was not as low and as well correlated as the left. The right, we didn't have a FFR. And does it speak to Babato's point that this very low FFR in LD does predict a very diffuse and focal multiple lesions? And does it predict outcomes in this case?
Yeah, I fully agree. So probably the FFR CT here is 0.74, but we have a tight but very focal lesion. On the contrary, in the CTA, you saw a very long lesion in the previous slide, and potentially we can also try to identify the true normal to normal. And the PPG probably is indicating not a focal lesion, but a diffuse lesion. So I fully agree with Emanuele. So here we see a potential application of CTA for the planning of multivessel disease patient as our live case, particularly the group of Cerise and of Collet documented that the feasibility to apply the syntax score to CTA through a non-invasive fashion. This is a case we calculated from a syntax tree trial. We can score exactly as in invasive fashion, the more than 50% stenosis, taking into account the parameters as the length, the presence of heavily calcific lesion, the tortuosity, the CTO. Otherwise, the literature showed that particularly a sub-analysis of syntax 2 published in JACC that the agreement between CTA and invasive angio syntax score is good, but not perfect. We have an overestimation in CTA related to calcific component of the plaque. Otherwise, if we can incorporate the FFRCT into a functional syntax score, as we did here on the right, removing 3 of the 5 lesions scored in an anatomical fashion. And in this case, the JACC paper from Collet showed a perfect agreement between functional syntax score calculated invasively and not invasively. So in this case, you can see a 3-vessel has been reclassified in a sample 2-vessel patient with just a stent to put in middle AD and in the distal right. So this is a potential usefulness of this tool in complex patient.
So maybe last comment on this patient where you have seen the imaging on CT. How does it help you plan the procedure even before you do the angiogram?
So I think that one important things we can try to do, so Emanuele again stressed the diffuse anatomical and functional disease in this patient. So you can see that in fact, the disease starts at the ostium of the left main stem and end in the mid to distal part of the LAD. So then probably we have a focal delta FFR in the proximal lesion exactly there, immediately before the calcific component. And then probably we can suppose that to treat that region allows to improve the FFR and the outcome of the patient, despite a potential residual functional disease due to the very long and diffuse atherosclerosis that we can address with an LDL reduction, very strong accordingly to the guideline.
Thanks. Maybe I'd like to pick the brains of some of the other panelists. Is this, would you agree? Is this what you are going to see on intravascular imaging as well? Dijan, is this well correlated?
Well, it does look like that. I think there are at least 2 points that we need to consider after looking at the intravascular imaging and planning our stenting strategy regarding the lesion in the mid-LAD. The first is, since we saw also on FFR that it's a pretty diffuse disease, I think then the landing zones of our stent are going to be important. We know from the ultimate trial that one of the measures predicting stent-related events in the follow-up that matters the most is plaque burden at stent edges. And if it was more than 50% in the ultimate trial, it did predict the stent-related events, actually the most, more than stent expansion in the ultimate trial. So this will be very important in this case, which is diffuse. So we need to be sure on the OCT that we have the landing zones that we want in the mid-LAD. The second thing that this has been talked about extensively is that we may need some sort of a plaque modification device prior to stent implantation, given the circumferential calcium at one point that is very thick. It's above half of millimeters. So we may need some sort of plaque modification there. Now, those are the 2 points regarding the lesion in the LAD. And there are also 3 points regarding the fact that this is a bifurcation lesion. The first point is just looking at the angiography, you see this is the only diagonal branch that you have. And we know from the SNU criteria that having only one diagonal probably implies that it is physiologically and probably prognostically relevant. So we need to pay attention to this diagonal branch. The second point is, it looks like fairly a 90-degree angle, which may be linked to a less of a jeopardy of acute occlusion risk, but it may also provide some chances for putting up a second stent if we go with a provisional in a T direction or top direction, given this favorable angle. And the third point, which I think is also important, it may be important to see what FFR values do we get after, for example, going with provisional, placing the stent in the LAD, and then performing a kissing balloon inflation with a short overlap and NC balloons, so reducing the risk of dissection, and then remeasure the FFR and see if we get it above the ischemic threshold, because at the beginning, we did measure the FFR, but it also counted the lesion in the proximal LAD, which we saw on the FFR CT was, for the most part, responsible for the pressure drop along the vessel. So I'm curious to see what's going to happen in the cath lab. It's certainly a very interesting case.
Thanks. We're also looking forward to going back to the cath lab. Dr. Guo, anything else to add on to?
Good afternoon, everyone. This is a 44-year-old male present stable in China. And the risk factors is an inactive smoker and family history of a heart attack. And the CT scan showed us that the patient had a severe calcium in the mid-LAD. And to the best of our knowledge, by far, I think compared with CT angiography and intravesical ultrasound, OCT is the most accurate modality for detection, localization, and qualification based on its high definition and resolution, which offers optimal lesion preparation strategy. For this patient, we know that to diagnose and treat the calcified lesion with OCT, I think we should start PCI with MID max workflow and assess a plaque of the calcification, and that's deep or superficial and nodular. And I think before Professor Ho showed us the result of the LAD and the diagonal, I guess that the patient maybe is superficial and the calcified score is less or equal to 2. And I think we apply OCT guided treatment calcified lesion algorithm is use the special balloon, I think ASE cutting balloon is enough to for lesion preparation of diagonal and LAD. That's all.
Thanks, Dr. Guo. So maybe a balloon cutting type of balloon rather than arthrectomy. So maybe just a quick one. I think what is the best modality to check on the calcium? I think in terms of sensitivity, all modalities are good. It's quite easy to pick up calcium. But in terms of overall form, thickness, and more specific ask on what to look at in the calcium, OCT far outperforms either CT or IVUS, except for the group that really is in a far location calcification where the light cannot penetrate. So it may be useful to just quickly bring the group to this flowchart algorithm on the treatment of de novo calcified lesion by our American colleagues. I think it is worthwhile going through this briefly. If your intravascular imaging catheter cannot cross the calcium and your catheter cannot cross, then we are looking at some form of arthrectomy. If you can use intravascular imaging to assess whether it's a deep, superficial, or nodular calcium, then I think you have a strategy. If you have a nodular calcium, they advise straight up arthrectomy. Superficial depends on the criteria of calcium thickness of more than 0.5 millimeter, length of more than 5 millimeter, or arc that's more than 50%. If you do have all of this criteria, and then you need to consider some form of arthrectomy, and if it's balloon crossable, IVL is preferred. If it's not, go to arthrectomy. And after you assess the lesion, you treat with whatever means. Do assess the calcium fracture, pre-dilatation before implanting stent and optimizing. If all else fails, they do advise going down to some form of excimer laser. So let's come back to our next comment by Professor Shinke on whether you agree on this algorithm and how will you treat calcium based on imaging. Prof.
Yeah, thank you very much for inviting me for this very fascinating session. So our practice is pretty similar to that algorithm. We in Japan appreciate OCT imaging to see the calcium distribution and thickness and take up low tablator or orbital atherectomy. Unfortunately, lithotripsy is not available in Japan yet, so we have a choice of low tablator or orbital atherectomy. And in many cases, we can use cutting balloon or some scoring balloon to manage the calcium seat. But I think in this particular case, today's case, I prefer to use low tablator to modify the circular calcification and to see OCT images to seek for the so-called landing zone. So for the stenting, we should stent from normal to normal. So for that purpose, OCT imaging is also very important. Thank you very much.
Thanks, Dr. Shinke. I see a lot of progress in the cath lab. So I'll ask Dr. Lei Song to hold his thought first while we go back to the cath lab for his comments as well. So Dr. Chia, can we go back to the cath lab? Dr. Hao, if you can be unmuted, maybe you'd like to tell us what's happening in the cath lab.
Yes, I just listening to your discussion. It's very interesting. And I have my strategy because from the OCT examination, we know that it's the real bifurcation and with the proximal serious calcification, circular one, at the proximal LED, and the proximal diagonal is also with the serious calcification, and the skull is a 4 point. And so we just choose I think that the first scoring balloon along a diagonal, and this is 8 ATM, and this is 12 ATM, and you can see the balloon, the shape is very good. And then to dilate the LED, because I determined to do 2 stent strategy, and after the scoring balloon for diagonal and LED, I do OCT examination to make sure about the calcification preparation is good or not. And you can see the result for diagonal with a good result. And you can see here is the after the scoring balloon, 8 to 12 ATM, and the at the calcification site. Okay, you can see we open the calcification with the fracture, and the area of the lumen area is good. So the preparation for diagonal is good, and then we just examine the LED. The LED, and you can see that the other part of LED for the preparation is good, but at the circular calcification site, and and you can see here, we just has a very small fracture, but not with big fracture. And so then we determine to use the NC balloon. This is 2.75 NC balloon, and we use it to up to 16 ATM. And after that, we do OCT examination again. And you can see here, just the same part, the calcification, the ring opened. Okay, you can see the big fracture. The fracture is become bigger. And after that, we determine to do two stent. And because just the diameter for diagonal from OCT examination is 2.75. And for just the middle LED is 2.75. Is the similar size. And so we just first choose the 2.75. 23 stent along diagonal, and we want to use the culotte strategy, two stent strategy for this patient for the bifurcation. And this is the first stent along LED, along diagonal. But we meet some, I think, like difficulties to just revert to distal LED, but it just minutes we saw it, and you can see here. Next. Okay, the final, and we just put together where to the distal LED. Next. Okay, and this is 2.5 balloon to dilate it, and then this is 2.75 33. And we want to, from OCT examination, we want to use two stent and to the proximal part of LED. And I now finish this bifurcation two stent. I want to put another stent along proximal LED. Hello, Jack.
Thanks, Dr. Hao. That was very nice. I'd like Dr. Lei Song to jump in now. Maybe you can offer some comments on the pre-dilatation OCT results.
Okay, thank you. And I think from the Professor Ho's procedure, in the preparation, the OCT-based scoring is also 4 points, but you using the cutting balloon, NC balloon, you with the OCT finding, we can find a good rupture. So based on this finding, we can we do not use any further invasive procedure to prepare the lesion. And I think that's one of the OCT advantage, not only to tell us how to prepare the lesion, but how to evaluate the effect of our preparation and to predict the extent expansion. I think is most important. Good job. Thank you.
Thanks, Dr. Lei Song. We have two other OCT physiology experts here, Professor Akasaka as well as Dr. Jose de Torre. Maybe I can get Jose to comment first so far on the results of the OCT and PCI. Jose?
Okay, thank you, Dr. Huai. I think this has been an example of how you can anticipate, as we have been discussed frequently today, by non-invasive CT imaging, that you are going to have a problem with the PCI, not a problem, but a complex PCI, because of the calcification, the diffuse, etc. Also functional assessment, of course, but we are talking now about calcium. Then OCT provides nice insights about how the calcification is concentrated, distributed, and present in the artery. We can identify the hot spots, those when we are going to need more aggressive preparation. And it was nicely shown how with NC balloons, the plaques were fractured, because OCT, or I was the technique you use, in this case, OCT, is helpful to plan the procedure, to select the best tools, NC balloons, lithotripsy or rotablator, and then to monitor the changes in the plaque just before the stenting. Then you can go forward to a stenting safely with the guarantee that you're going to have good expansion, like in this case, and also for an imaging, you can select the lamping sites and the length and etc. Good case, yeah.
Thanks, Professor Akasaka. Any further comments on the OCT part?
OCT part, yes. As Professor Ho already explained, there are severe calcification in the proximal to the diagonal branch, right? The LED proximal site. But there are some yes part very thin. Therefore, the Professor Ho select the modified balloon technique. That means scoring balloon, cutting balloon, right? There are some study comparison between rotablator and the modified balloon technique. The final results are not different between the both technique, but some overlap in a case with a modified balloon to the rotablator. Therefore, if the modified balloon technique is very good, we can put the stent after the pre-dilatation lesion preparation. Yes, so I enjoyed the discussion very much, and results seems to be very wonderful. Thank you.
Thanks, Takashi. Dijan, you've seen the procedure so far. Does it match what you were thinking of before you commented?
Yeah, well, it's progressing nicely. In my opinion, I think provisional would have been an option as well, but the operators decided otherwise. What I think is important is that they showed a very well preparation of the ostium of the diagonal branch, and I think this is an important thing because in many bifurcation PCI techniques, the ostium, especially if you're performing a double stenting, the ostium of the side branch is sometimes a weak point in terms of the stent expansion. So I think it was a very important to show that there was a crack in calcium and that they prepared well the ostium, because the result at the ostium of the side branch is very important in terms of the long-term outcomes, knowing that many cases of restenosis occur at that point if you perform bifurcation stenting, and especially with two stents.
Maybe I would like Professor Zhang Junjie to jump in now on his take on this two-stent upfront strategy. Any comments, Professor Zhang?
Yeah, Dr. Ho did a good job in terms of the LAD and diagonal bifurcation lesions. According to the definition criteria, it's a typical complex bifurcation lesions. So I fully agree with the user's two-stent technique for the treatment of these complex bifurcation lesions. In my style, I will use DK crush for this particular case with intracranial imaging guidance. Yeah.
So maybe you'd like to share with us why would DK crush be your preferred strategy over QLOT here?
Yeah, actually, according to our experience, DK crush for the complex PCI, especially for left main, actually superior to QLOT. However, in terms of non-left main bifurcation lesions, I think either QLOT and the DK crush is suitable for this case. But for me, I think I was more comfortable and more familiar with the DK crush technique compared with the QLOT. So as this scenario, I will choose DK crush for the first choice.
Thanks, Professor Zhang. Dr. Hao, anything from you before we break off for a while before coming back? Anything else you'd like to share with us?
Okay. I think that this is okay. You can see from the angio. We just put the proximal stent, just the proximal of the bifurcation. This is the position of the root of LED, and so after that, we just reveal to the diagonal, and this is use 2.5. It's very simple to put the guide wire into the diagonal to pre-dilate it. And now we want to use 2.75 NC balloon to just the casing for this bifurcation. Professor Jack?
Yeah, so I think we're all very keen to see, particularly not just the final results on intravascular imaging, but and also
you can see the angio result before the pre-dilation, and you can. This is the angio result.
The angio result looks fantastic, and we are very keen to see the intravascular imaging as well as the physiology after all this stenting, particularly in the LED. But Bato is predicting that the FFR may not correlate very well with your intravascular imaging. It looks fantastic at the moment, but we're waiting to see that. So perhaps I can break off a while before we come back to take some audience polling questions. We'll come back to you in a bit, maybe in another 10 minutes time. if you're okay. So we have some audience polling questions, Dr. Chia, and how would you assess or treat heavily calcified lesions? Is it angiogram is enough? If you can cross with a balloon, dilate, if not, then rotoblade. I'm using only imaging at a single tight lesion cross-section, or I usually do some form of a pullback. So this is the result actually. So a lot of people say that they will do imaging, IVUS OCT pullback, and if the balloon cross well, then dilate, if not some form of tracheotomy. Any questions from the chat at the moment, Dr. Chia? If not, I think diffuse lesion is what we're going to discuss next. This case definitely fulfills both multi-vessel as well as diffuse lesion, particularly in the LAD. We had some issues with the FFR reading being surprisingly extremely low in the LAD when the lesion looks fairly focal. So assessment of diffuse lesions is always going to be tough, and multiple segment cross-section cuts in either IVUS or OCT just shows you the cross-section, but it doesn't quite tell you the full answer. So PET section, and you always have some issues determining lumen area versus EL versus the total plaque burden, but I think you need to take all this into consideration. And we do know that the outcomes at the end, when Dr. Hao is going to demonstrate to us, we do need to optimize the stand result in terms of the final MSA to vessel normal reference area. And this, this study by Ujima in the depth ACS, DES result does show that if you get a good optimization as close as possible, at least more than 90% to reference area, you do have a better long-term MACE rate outcomes. So in this other study, which is pretty interesting to me, physiological pattern of disease as assessed by a pressure wire pullback has an influence on the FFR, IFR, or RFR discordance. So I think in a subset of patients where there is a negative FFR but positive IFR, it tends to suggest that the lesion may be more diffuse, in contrast to cases where the IFR is negative and the FFR is positive. You may have a mix of a predominantly more focal lesion. And Barbato actually spoke to this earlier on when he talked about the importance of having some form of pullback curve to assess whether you're dealing more with a sharp drop-off focal lesion or predominantly drift like a diffuse lesion. So maybe we'll call upon some expert opinion about how do you actually assess diffuse pattern to guarantee good outcome. Is it an imaging directed, or is it a physiological index that you can count on when you're treating this patient, particularly a young patient with diffuse disease? We can call upon Dr. Yong to make his comments first.
Okay, thank you. So for diffuse pattern of disease, I think this, of course, the imaging and physiology guide is very important to optimize the PCI, including the, I think, the procedure planning. Of course, there are two, usually in our case, there are two popular imaging modality, both IVUS and OCT. But for it depends which imaging modality we should use. It depends on the disease characteristics. For example, for the patient like today, that demo, I think if it's diffuse with very calcified, I think maybe OCT has a disadvantage over the IVUS to see the full characteristic of the calcified. And for physiology, I think, but for some patients, if you have renal dysfunction and the multi-vessel disease involve the left main, I prefer to IVUS, of course. And for physiology, I think because for especially for some diffuse disease, if you only do FFR and with hyperemia and it's time consuming, and maybe during procedure and co-FFR, I think is a better choice in the future if you can have this available. It's my opinion. Thank you.
Thanks, Dr. Adrian. So what predicts the long-term outcome in this case, you think? Which physiological index? Is it IFR, FFR, CFR, IMR? Maybe you can let us know your opinion.
Sure. Yeah, I think that's a difficult question here. And this patient clearly has a very diffuse LAD disease. My personal bias is actually for an FFR form of evaluation rather than a non-hyperemic index, because I think in most of our experiences, especially in patients who have diffuse disease, you do see quite a bit of discordance with the rest indices. And I've just been comfortable over the years to actually do an FFR pullback gradient, and that will help to guide actually whether there are any focal lesions along a diffuse disease that might potentially be amenable to spot stenting and improvement in the subsequent physiology. I think in this case here, the original discussion was on whether there was such a focal stenosis in the prox mid-LAD lesion involving the diagonal branch, and whether addressing that would actually relieve the gradient sufficiently to improve flow distally. And I think that's what we're all actually looking forward to too, after having the very good angiography result that has been performed. I do think that the patient still has quite a lot of diffuse disease distally, and I'm not sure how much more we have gained, although we have certainly improved the proximal inflow for this patient. So I think the interesting part is that the focus in future interventions, I think a lot would be on evaluation of diffuse disease and how actually to best use physiology to guide the treatment of these patients.
Thanks, Adrian. And this is an audience poll. Which imaging would you use to guide PCI and diffuse lesion? Is angiography enough? Is IVUS superior? Is OCT better? Or will you do both? I think that initially, I think we have a mix, but now when more audience submit, most folks think that OCT is probably better for accuracy, especially calcium assessment. Anything else to add on to this piece? Maybe you can switch back to the cath lab as well. Daniele, do you have any other comments about diffuse lesion assessment?
No, so I fully agree with what the other people told. So probably here in the invasive fashion, as Barbato mentioned, and a pullback pressure assessment, a pressure gradient assessment should be definitely interesting to see if we have a functional focal lesion to treat, or if we have a diffuse disease also from the functional point of view. So, however, I fully agree that the cath lab is performing a perfect procedure, and the angio findings is fantastic.
Thanks. Barbato, maybe you can jump in now. We all agree that what we saw on angiography looks good. We're going to look at intravascular imaging. But will your prediction still be that the FFR may not be optimized here, Barbato? I think Barbato may have dropped off. We'll transit back to Dr. Hao. Dr. Hao, maybe you'd like to show us what you have so far.
Yes. Can you hear me?
Yeah, go ahead, Dr. Hao.
Yes. And now we finished the casing and the post-dilatation for the proximal LAD. I will show you the result of the angio and OCT. First, let's see the result of angio. Okay, this is the proximal post-dilatation. This is the casing balloon. Next. Okay, and now is the OCT examination for LAD. And you can see the result of LAD OCT. The middle part of the stent expansion is good. This is the bifurcation is good, the shape. And the proximal stent, the expansion is good. And maybe Professor Huai will examine the expansion ratio. And then we do the OCT examination for diagonal.
Maybe you can ask Professor Zhang to comment on this final result on the bifurcation segment. Is this a good result?
Yes, and you can see the diagonal, the opening shape is very good for the culotte to stent, and for this patient, I think that from OCT examination with the good result. And panelist, you can comment. And I will do the final FFR for the IOAD.
In terms of non-left main bifurcation lesions, if we treat it with a two-stent technique, DK Crush 8 proposes a new criteria, 655. 6 is a proximal main vessel. 5 is a distal main vessel and the ostimal side branch. So I think from the OCT evaluation, the ostimal diagonal is nearly 5 square millimeter. I think it's got a good stent expansion.
Thanks, Dr. Zhang. There's also a question from Takashi asking us to discuss what kind of FFR value do we think is acceptable for such a case to have a good long-term result? Maybe we can get back to Eugene. Do you have any comments on the final FFR reading?
So I think we want to see a final FFR of more than 0.8, of course. Otherwise, we still have residual ischemia in the distal vessel. Usually in my own practice, I tend to use resting indices and only go on to do FFR if the resting indice is not good. So I usually take 0.8, 0.95 or above as a good result. So if the resting indice is about 0.95, I usually don't bother doing the FFR. If the resting indice is below that, then I will do an FFR to see where we're at.
Zhang, will you agree with that?
At least 8.5 or more.
Yeah, that sounds fair to me.
Yeah. Any personal opinion from Professor Takashi? Is that what he does as well? Prof. Akasaka?
Yes, if possible, yes. FFR more than 0.90 should be the better. But yes, in this case, a very complex disease and diffuse with focal disease. Therefore, 0.85 might be okay if the OCT result is good. Yes.
So we are waiting with a bated breath to see whether it's 1.0 then. But any comments from Jose Vittori? Is that your guidance as well?
I have a comment regarding the use of FFR or IFR to check the results after stenting, because we have to be careful, because maybe pursuing a very excellent number, you are going to stent very long segments of the artery, lesions that were not significant at all at baseline, and then we are really missing the point. I think that there is not enough evidence to demonstrate that we have to leave the arteries with a certain value over of FFR or IFR to improve the outcomes. We have to treat the lesions that are significant at baseline and to optimize the stenting in those segments. The rest of the vessel maybe has disease, but it's a diffuse disease that is not significant at that moment. And maybe the best is to have a very good secondary prevention, but you should not target numbers to get over 0.95, 0.9, just to treat the segments of the artery that were significant in the baseline examination, and then to optimize the most the procedure by using of intravascular imaging.
Thanks, Jose. Again, very good comments. Babato may be right. I saw that FFR drifted quite low. Dr. Hao, your
yes, the IOD FFR is 0.84. And now it's diagonal. Hello, Jack. And do you think 0.84 is good for this patient because the distal part of the IOED with the diffuse lesions? And so I don't want to put so much stent for this young patient.
No, so I think I don't know the answer, but my own personal comments is that if you started off with a FFR of 0.5, I am not going to target a FFR of 0.98 or 1. I don't expect that. And you have a diffuse lesion after the stent as well. So I think you have a significant and well-demonstrated optimized stent in the proximal segment. You have a FFR that is more than 0.8, like what Eugene actually would prefer as a minimum. Whether you hit above 0.9, I think in this case, we're never going to reach there. So I'm quite happy with this result as long as most of the major step up from the proximal segment is gone after the final PCI. This is the final for the diagonal, 0.92?
Yes, 0.93, very good, better than ILED. Because the middle and distal part of the diagonal is just normal.
Dr. Adrian, though, are you happy with this?
Yeah, I don't think I can do better. I think that's an excellent angiography result and correlated with the marked improvement of the FFR of at least 30 millimeter mercury gradient. So I think that's an excellent result and as best as one can hope for, given the diffuse nature of the disease.
And we probably still have to focus on aggressive medical therapy and stop smoking. So Dr. Hao, we are coming to the end of the last 5 minutes. Perhaps we can have you summarize our learning points for today's first day's session, Dr. Hao.
Okay, thank you, Jack, and thank you, everyone. I think that today, this is a very good teaching case, and because from the CT and the CT FFR, we know that this young patient with the multivessel disease, and from the CT FFR, we know the positive value along LED and the diagonal and the circ is very low for the FFR value. And for the RCA and the CT FFR value is near negative. And the very distal part is less than 0.75. But from the angio, some different to CTA and the CT FFR. And we know that this patient is really multivessel disease and diffuse lesion along ILD and the real bifurcation at the ILD and the diagonal. And we also observed stenosis along the circ and OM and really very tight stenosis at the distal part of the RCA. And so we must, we want to do imaging examination and FFR examination for this patient for a left coronary artery, because for so many vessels, how to do it and what kind of strategy, how to solve about the calcification and the bifurcation. I must very fast and to solve the problem of RCA with one stent technique. And then we go to left RCA. I think that the most help technique, the tools for this patient to do which vessel is FFR. From the FFR, the physiology examination, we know that we don't have a very high ischemia along the circ and OM, and so we just leave it for follow-up and for the medication. And then go to the ILD and the diagonal from OCT examination. This is the real bifurcation lesions, and along the opening site of the diagonal, very tight stenosis, and the calcification score is 4. And along LAD is diffuse lesion, and maybe we use OCT to choose the landing zone, the distal landing zone and the proximal landing zone. And we also notice that just proximal to the bifurcation with the very tight calcification, also the score is 4. And so we must before stent to stent technique, because this is a real bifurcation. And the diagonal is very huge, and so I must use 2 stent technique. And how to choose DK crush or Q-lot? I just by OCT examination, because the diameter for diagonal and the middle part of LAD is similar, is 2.75. So we determined to use the Q-lot technique for this patient. I think that is suitable. And so how to before the stent implantation for the highway calcification, we must using some tools and to prepare calcification. And we first using scoring balloon and get a good result along the diagonal. But for the LED and not enough. And so based on the scoring balloon, and we use the NC balloon and to a high pressure. And so from OCT result, and we can observe a better result for calcification preparation. And then we do the Q-Lot 2 stent for this patient, and another proximal stent after light gave a better casing and post dilatation for proximal LED stent. And from the OCT examination and the FFR physiological examination, we also, I think, that acceptable result for this very young patient. And maybe for this patient with the diabetes, we must use after PCI treatment, we must use PCSK9 inhibitor and maybe SGLT2 inhibitor or GLP-1 active GLP-1A, and so help them to do a better medication. I think that this patient need 1 year angio and OCT follow-up. That's all. Thank you.
Thanks, Dr. Hao. So on behalf of the panelists and myself, I'd like to congratulate you for excellent result as always. Great demonstration, and I really like your finishing point. I'd like to invite Professor G now to give us the final remarks and close the session. Dr. G, please.
So, Huai, first of all, thank you very much for leading this incredible demonstration. We went through a live case. They had a lot of challenges point at the beginning. You remember multi-vessel calcification, and we did a step-by-step on what we are calling actionable contribution of imaging and physiology. And we had these extremely nice results. And what I would like to do is, first of all, say that thank you very much across the globe, because it was a fantastic demonstration of interaction of people coming from everywhere. And thank you very much, especially to the Cath Lab, where Dr. Hu was superb in showing the different steps. And do not forget that tomorrow at the same time, we will have a second case with still a very interesting setting to deal, and still large group of facilitators and panelists. Thank you very much for stay with us, and see you tomorrow.
Thank you, and goodbye.
Bye.
Bye.